afternoon, and thank you for attending today's webinar, The Intersection of Primary Care and Public Health through Oral Health Services for Students in the School-Based Health Center. Please help us count. If you are viewing as a group, please go to the chat window and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Just a few reminders. All attendees are in listen-only mode. However, we want to hear your questions. So if you have a question, please, at any point during the webinar, go to the chat box located in your GoToWebinar control window. We will address questions following the presentation. Attendees will be asked to complete an evaluation at the end of this webinar to let us know how we're doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website. You may access our archived webinars by visiting www.sbhforall.org/webinars. We expect that by the end of this webinar, you will be able to discuss the significance of oral health disease in children and youth, list 3 strategies for preventing dental caries using school-based health, individual, and population-based approaches, and 3, explain how a school-based health center working with other community resources can provide care to children with dental disease and can participate in prevention initiatives. Before I introduce our panelists, we'd like to have a little audience participation. In just a moment, you will see a poll question appear on your screen. Please answer the question, do you or does your organization provide direct patient care to children and youth? Five more seconds. Thank you. It looks like 53% of our respondents say yes, they do or their organization does provide direct care for children and youth, and 47% say no. The panelists we have presenting today are Jane Hamilton, who's an RN and has worked in school-based healthcare for 23 years. She now manages 19, soon to be 20, school-based health centers in rural upstate New York. She serves on multiple boards and committees focusing on population health and children's health care. Our second presenter, Leah Carpenter, joined the Bassett School-Based Health Team in November of 2013. She was directly involved in the development and implementation of restorative dental care at 3 school-based health centers. Dr. Carpenter has been a strong advocate for children's oral health care and has worked with Carissa Newbert and Betsy Bray to bridge the gap between somatic and oral health care in school-based healthcare settings. Elizabeth Betsy Bray has worked in the field of dental hygiene for 25 years and school-based health for 10 years. She presently provides direct clinical care to patients, is the coordinator for the HRSA Children's Oral Health Access Project, and serves as a dental liaison for Dental Trade Alliance Foundation funded project Integration of Oral Health into a School-Based Health Program. And lastly is Carissa Newbert. Without further delay, I will now turn it over to our first presenter, Jane Hamilton.
Thank you, Letitia. We are thrilled to be invited by the Alliance to share our oral health story. Oral health care is an important part of our entire program here up at Bassett. And I think we'll start by showing you a short video. Letitia, are we set with that video?
Dental care is important for children as far as their state of well-being. We know that dental caries and poor dental hygiene has an impact on long-term health. Recent studies have shown that, in fact, the chronic inflammation of some dental problems may have long-lasting effects on the cardiovascular system. Over and above that, having bad teeth is socially just not a good thing. That will affect how they relate to other children and how they relate to people in their environment. There's a huge challenge for families in rural areas that prevents them from accessing both somatic and mental as well as mental health care. Some of these barriers could be breached by putting the care in a school like we do. Good dental care for kids provides them with a pain-free state that allows them to attend and pay attention and learn in the classroom. One of the issues that's facing our country and our health giver profession today is that we tend to fund for problems. We don't fund for prevention as well. And it would be really nice and very important for kids if we could fund prevention, because that's what we're about in taking care of kids, is preventing the problems that later on are what are covered by funding mechanisms like insurance.
Thank you. I do apologize for the quality of that video, but they are available on YouTube, and at the end or afterwards, we'll send Letitia the link to all. We're going to show you another short video, and hopefully that'll be a little bit better. You're looking at two maps right now, and I just thought it was always useful to kind of have a context of where we're from and what we're talking about. We are okay, so I just got a little message on my phone, but I'm hoping you're still hearing me. So you can see the white cutout in the middle part of New York State map. That is where we're located. And then on the right-hand side is the cutouts of our county. All of the yellow stars is where we presently have school-based health centers, and as Letitia mentioned, we'll be opening our 20th school-based health center here in the next hopefully next month, and that's where the red star is. So I think we're going to do a poll question next, and Letitia's going to help us with that.
We'll give you about 10 more seconds to answer. Okay, we're going to close the poll. And our results show that 88% of you believe that dental caries is the most common chronic health problem, 6% obesity, 0% depression, and 7% asthma.
Thank you. I think it was probably a dead giveaway with our program today what the answer was going to be. But we use that question a lot when we do community meetings. And actually, asthma is probably the condition that most people think of if they're thinking of chronic illnesses. Sometimes we kind of go down the acute road. You know, I think what's so telling about are so striking about dental caries, and that has really caught all of our attentions and obviously the nation's attention, because it's a big piece of the Healthy People 2020, is that it is so preventable, and we really do need to figure out a way to address that. And I think we have. It's just making the wide impact. This is just a quick timeline. Just wanted you to see our program has really been evolving over years. What we're doing doesn't happen overnight. We really started nearly 15 years ago with a very basic program that really focused on referrals, and we added preventative health services, dental services, got a little more sophisticated with referrals, and now bringing us to where we are today with really integrated it into the primary care and providing full restorative care. So I think we're going to do another poll question.
About 10 more seconds. All right, and here are our results. 50% of you believe that, 55% of you believe that 50% of children ages 5 to 11 have at least one untreated decayed tooth, 39% at 20%, 3% believe 10%, and 3% believe 5%.
So this is Dr. Carpenter. Thank you, Letitia, for that poll question. It's actually not that bad, everybody. It's actually only 20% that have an untreated cavity. But when we start talking about just permanent teeth, the numbers aren't great. So 1 in 5 kids ages 6 to 11 have an untreated or treated cavity in a permanent tooth. So that's, we look at Caries experience, and about 20% of kids 6 to 11 have Caries experience in a permanent tooth. And when we get to the teenagers, the number jumps to 3 and 5. So cavities is alive and well in the U.S., and it's not just affecting baby teeth, it's affecting the permanent teeth that kids are going to have for the rest of their life. In addition to just causing overall poor health that Dr. Chris mentioned in the video, it also causes missed school hours. About 51 million school hours are lost each year to dental-related illness. And all that disease adds up. So, you know, obviously kids sitting in a class with a toothache can't learn if they're in pain, and they also can't learn if they're taking time off of school to travel to a dental appointment, which in our rural area is a significant amount of travel. So one of the advantages of our school-based program is that we're treating the kids right in the school so that they might only be missing one study hall as opposed to missing a whole day to go get the dental work that they need. And obviously, if kids are in pain, they're going to have problems eating, speaking, and paying attention while they're in school. And while we can't measure it as well, a lot of the social pressures of school, especially among teenagers, contributes to low self-esteem, poor, lack of smiling, all those problems. So there is some good news, and that's that we've seen a decline overall in caries prevalence in the last several decades, and that's true in New York State as well as nationally. And you can see from the graph here that all children experienced a decline of untreated decay between 2002 and 2011 of more than 10%. However, in that same time period, children from low-income families had a higher rate of untreated decay overall, and they didn't show as big a decrease as the kids from higher income families. So in school-based health, we don't specifically collect income data. So our green bar there that you can see for our school-based third graders shows the untreated decay on par with the low-income numbers. And anecdotally, of course, we can verify that most of our kids do come from low-income families. So that kind of points towards the disparities that we see in oral health care. Our area in upstate rural New York is no different than the disparities nationally, except that we probably have less minorities here than nationally. But overall, dental health is improving among Americans, but there's still a lot of unmet needs among poor children. And a lot of the studies you see make reference to high and low socioeconomic groups, and sometimes low income is a stand-in for that number. And this is just a little bit of information about our particular area where we're doing restorative care in the schools. So we practice in 3 different schools doing restorative care, and that's Delaware County, Otsego County, and Shenango County. And you can see we're kind of on par with the national averages for individuals that are living in poverty, but kids do make up a significant amount of the people that are living in poverty. So in trying to figure out, which kids are highest at the most risk and have the highest needs, there was a study done in 2006 in the journal Pediatric Dentistry that compared children from low and high socioeconomic groups, and they controlled for fluoride exposure and toothbrushing habits. Those 2 factors were pretty much the same between the 2 groups, but the lower socioeconomic status children consumed significantly more soda and powder-based beverages, and not surprisingly, they also had a significantly greater caries experience. So that's one of the things we're trying to do in school-based health is really target the nutrition messaging, and that's a big part of our integrative efforts that we have with our somatic school-based team. And Carissa will talk about that a little bit later, but just to mention that now, the 5210 campaign has been a big part of our educational efforts in school-based health, and the 0 of that 5210 message, in particular, 0 sugary drinks, is a big part of what we try to instill in the kids to avoid not only somatic health problems, but dental health problems as well.
Good afternoon. I'm Betsy Bray. You may be identifying with some of the things that we're talking about today in your own communities. And so what I'd like to share with you is to talk a little bit about where to start. As you can see, I have on the slide next is talking about what's happening in our state in particular. So where to start? Stakeholders have considered oral health with regard to population health. So going outside our own silos and really seeing what's happening, a place to start would be to investigate what's going on in your own state and the local, regional, and state level as well. What's currently being done? How can your ideas fit into that model? An example would be the New York State Prevention Agenda. As you can see, these objectives have been identified as ways that we would like to work towards improving health among our population. So with some of the ideas that we have in mind, we're trying to match with what's happening on the state level so we can achieve those goals. So some of the things that are proven to work and are recommended in our state are these interventions. As you can see, we've got counseling and education, protective interventions, clinical interventions, policy, and socioeconomic factors. Go ahead. Sure. So counseling and education. This is one variable, but alone, we found doesn't work. What's great about it is you can increase your access about the subject at health fairs, As you can see, some examples are some individualized group discussion with certain age groups. We've got the tooth fairy making an appearance. And on the left, we have different health fairs where we're really targeting those caregivers. So for education, we're focused on specializing on one-on-one and also in a group setting. So the evidence-based measures we're identifying them to be effective, and we utilize all those aspects in our program. For the protective factors, these are more of the clinical interventions. We have sealants and fluoride having the most effect on our meeting those prevention agenda goals. And you can see one of our staff members there, one of our hygienists, is placing sealants on a patient in our school-based health setting. So to talk a little bit more about those protective factors before we go on to champions, the other three that we have are the clinical interventions, which we don't have a picture to share with you. They're peppered throughout the presentation. You'll see our dentist, Dr. Carpenter, working with the team to provide some clinical interventions. What we found is that when we can identify in our settings the restorative needs, we can provide that care right in the school setting. And in the process of our program, we identified that the barriers to care are finding specialists in our area. So we've identified new areas and interventions as we go along. An example of this would be to provide a root canal therapy. It's a specialty that our families have to travel great distance for, and now we're able to provide that in-house. Not on the screen, but also an evidence-based measure is policy. You're going to hear Jane Hamilton speak a little bit more about that, but that is also a big aspect of what we do, identifying the stakeholders and really being involved in advocacy on many different levels. And then, of course, focusing in on those socioeconomic factors. We try to eliminate the barriers. We have an understanding of the culture of poverty, and we're trying to connect those families to resources. So together, education, the protective clinical factors, those restorative interventions, the policy, and the socioeconomic factors, understanding them in your communities are really the building blocks of what to build your projects on. We'll move on to discovering champions. So once you've identified ways to improve health populations in populations that you're serving, we're going to look within our community for advocates and champions. You know, these are already people that are doing great work where you are. So, and some examples of that would be school nurse. A school nurse in your community is trusted. They're student-centered, and they're really the hub of where a lot of things happen in your community. Also, to focus specifically on oral health, we have dentists and doctors in your community. They may want to give back and be a partner in giving time. Maybe they can share some financial resources with you, or maybe they can offer you some supplies. So looking within your community for dentists that could give back. They also oftentimes are parents in the community as well, and they want to see their communities healthier. Another example would be teachers looking for ways to improve the students' health. So, you know, really going about this, thinking outside the box a little bit and looking for these champions and advocates in your community. So what's really important is you may have some great ideas. Today you may hear some building blocks for how to get started. Once you're listening to some of those meetings and understand what's happening in your community from a health perspective, you want to be really looking out to be able to identify partners. And it's really important to have these partners for many different reasons. We want to be able to have funding for a startup and also for some ongoing support. So it's using a public health approach and looking outside your silos for other groups who have similar goals in mind for healthy communities, whether they be, some of you today are working with children, but others are not. And so with those groups as well, in many areas of oral health across the lifespan, you may notice that oral health is on these agendas to improve population health in your community. So what's really important when you're trying to identify partners is really understanding the data. You really have to have relevant data in your subject and in your community as it relates to how it can have an impact. You want to really be able to project what the outcomes will be and really look to see how you can really enhance the existing programs around you. You may not have to start from scratch. An example of this would be, for us in particular, we wanted to merge two programs. On their own, they were both limited. One was focused on a case management component where we were helping families connect with insurance and a dentist. They were identified as needing care, but they just didn't quite know how to connect with care. Maybe the barriers were transportation, maybe they were lack of insurance funding. So we were really that bridge to connect them with those resources. And another program simultaneously was a sealant program. So a hygienist was out in the field providing preventative services limited to placing dental sealants on permanent molars. And on their own, they were okay, but together they really made a robust preventative program. So we merged those two programs. And in the process of that, we were able to increase access, and the projected outcomes really helped us meet the goals that aligned with what's happening in our state. So you want to build on success. You can kind of see this little formula here. You want to be thinking, what's the mission? What would we like to do? Who is going to help us get there? What's happening around us in our own communities that we can tap into? And once we figure those two things out, we really want to start with that messaging. Maybe it's internal with the stakeholders at first, and then what's that messaging going to look like when we're focused, when it's community oriented? Is it focused to the caregiver? Is it focused to other area healthcare providers? And it could be a combination of both. So of course, there's always challenges. This all sounds very easy, but there are challenges involved, and we've faced them in our journey. So some are, we may be on uncommon ground. And what we've run into is some dental providers in the community may feel that we're a threat to them, competing with them. And it's really just having those authentic, open conversations of communicating of what our mission is and the population we're really trying to address. Sometimes you have delayed in the results you were going for, but you really kind of hang in there, get a strategic plan back together, and maybe retweak the original ideas, and be constantly looking for funding.
I think we're going to go to our last poll question.
Ten more seconds to respond. Okay, our poll results show that 94% of you believe that fluoridation of drinking water is the correct answer.
Thank you. Well, again, I think this was a dead giveaway with this question, but I think we're all hard-pressed to talk about oral health and not talk about water fluoridation. Again, you're seeing a map on the left of that catchment area that we deal in, and the dots represent our school-based health centers. You can see it's about half and half. About half of our sites have fluoride in the village, and it is important to understand that we live in a very rural area, and many of you may also. So the children that live in the village may have fluoridated water, but those that live outside the village, which is probably more than those that live in, do not have fluoridated water. You know, we have encountered a couple of situations locally in some of our communities that the communities were contemplating removing fluoride from their water. And we really kind of pulled together. We had an action plan. You know, we went to community or government meetings and really just, again, shared the evidence. We've also have shared evidence and with our intent to help build health literacy at some of our community advisory committee meetings, which include students, and really talk to them about reading the evidence. There is plenty of information out there, and you know, really helping them understand that everything online isn't always true. So again, we would be very hard pressed to talk about oral health without talking about fluoridation. And this is one of the areas that we can change the context of where we live. There are other areas that it's next to impossible, but I think fluoridation is something that we all need to be very involved with and very conscious of what's going on. The other place that, and a couple people have mentioned, wellness policies. And you know, this is just an example. Would we rather have kids have the Vegemite as a snack or a cupcake? And we in no way are saying kids should never have snacks or never have treats, and we really talk about them as treats, and that's once in a while. And we can do great education, and I think we do great education, but that's only really works in the moment. But we find people change, administration changes, and unless you have policies in place, what happens in the school is going to be influenced by the individuals and not really what is there embedded in policy and practices. I share this story often. We have one of our 14 school districts that we have been able to eliminate the sale of sports drinks. Now that seems like not a big deal, but it was a big deal, and it took a lot of effort. So changing policy or developing policy takes a lot of time. I mean, it can take months to years, but it really is kind of the foundation of long-lasting change, and I encourage you all to be considering that. We also try to help people understand this isn't just a tooth issue, it's not just the obesity issue, it's the whole person. And again, so my little spiel there about the sports drinks, and the same thing, trying to get schools to think more about and really changing policies on what beverages they're offering to kids, both during school hours and off school hours. They all have the rules about when they can sell the competitive foods, and actually the competitive foods, you know, the new laws will allow them to sell some of this other than water or low-fat milk. But again, by showing them the evidence, I'm really hoping we're going to start seeing some changes. So again, another place where we can change the context. Where we have a hard time changing the context is socioeconomic factors. We really can't create jobs. We can't increase people's wages. This is really just work that's beyond the scope of what we can do. And we don't say that often because we think we could do just about everything. Let's see, and I think it's for Dr. Carpenter to.
So this is Dr. Carpenter again, and I just wanted to talk a little bit about the nuts and bolts of what we do in restorative care. So ultimately I was brought in because our preventative efforts, while totally admirable and run by a great group of people, can't catch everybody. So kids do end up with cavities, as we learned earlier. So the way that I receive a patient in my chair and who I treat is a little bit unique to our program. So we don't advertise a lot. Our patients are referred to me by our school-based hygienist. One of our hygienists is pictured here with a student and a mother. And the hygiene program has been in place for many years, long before I arrived. And they're screening each patient they see. If they find a patient who does not have a dentist and has high unmet oral health needs, their name comes to me, and my dental assistant makes a phone call and offers the restorative care to the patients. So on the first appointment, the parent is present, so the kid is in my chair, parents are there, and that's a great opportunity to educate both the kids and the parents, because as we know, the long-lasting effects of restorative care are only good if they can maintain proper hygiene and home care. So the first treatment planning appointment occurs, and then many parents that we see are unaware of the extent of their child's oral health problems, or oftentimes we're trying to educate parents about the importance of treating baby teeth. A lot of parents don't see the necessity of treating problems with baby teeth, because after all, they fall out, and what's the big deal? So it's a great time to educate parents. And at that point, once we've developed the treatment plan, we can give the parents the option of signing off on having their child seen without their being present, depending on the treatment plan and depending on the child's age and behavior and the parent's level of comfort. And what we found is that not requiring the parents to attend treatments has really cut down on our no-show rate, and that the children, in fact, do much better in the chair when the parents are not present, because as we know, parents have a lot of dental anxieties themselves, and if they bring that to the dental appointment, that can have bad impacts on the child's behavior. So as I mentioned, ultimately we want our prevention efforts to be so successful that kids don't ever end up in my chair. But unfortunately, they do get cavities. And until that ends, the next best thing we can do is to make them comfortable with treatment and to make them confident dental patients. So in my day-to-day work, one of the best parts of my job is to get a kid who maybe at first is a little uncomfortable, who's afraid, maybe he's heard from mom or dad or big sister that the dentist is something to be afraid of, and we get them in the chair. We should kind of do a lot of tell, show, do, Miss Thirsty, we have a whole spiel, and by the end of treatment, they love coming to see us. And I get a hug at the end of treatment. That's a wonderful thing. So, and ultimately, these are kids who grow up knowing the value of good oral health, and as adults, they won't delay treatment. So, that's one of the long-lasting effects we can do. Even though we hope to make restorative work unnecessary, the next best thing we can do is actually make patients unafraid to come to the dentist and receive treatment that they need. So I think next we have a short video.
Dental care at school just makes sense. It's where the students are, and depending on their level of need, we can pull them back to apply a sealant or do a second cleaning during the year. To determine who is referred for school-based health dental services, from my perspective as a physician assistant working on the medical side, we do a oral health risk assessment as part of the child's complete physical exam, which they get every year. The school-based health dental program serves students of all ages, all the way from 3-year-olds and UPK programs through senior year high school students. And the level of care that they receive depends on their needs. So students receive prophylactic services for cleaning, sealant, varnish application, and if they need restorative services, there's an avenue for that to happen as well. Patients won't be denied services for lack of insurance, but we certainly encourage them to look at all the avenues that they have. If a family does not have insurance, you can connect them through facilitated enrollers. who can help them determine which insurance program might be the best for them. It's very difficult for a student who has a toothache to pay attention and learn in school. So that's what we're trying to ultimately prevent with offering school-based health dental services. We can offer cleanings and varnish to prevent these problems from happening. We've really made huge strides in caring for the whole child.
Okay, thank you. This is Carissa Newbert, and I am a physician assistant at one of Bassett's larger school-based health centers here in Sydney, New York. And I'm going to talk to you this afternoon about what integrating oral health care looks like from the medical perspective. It starts with a formal caries risk assessment on every patient. If a student has a tooth, then they deserve a caries risk assessment. And once we have established that risk, we can then make nutrition recommendations, maybe apply fluoride varnish, and make appropriate referrals. Remember, varnish is not necessarily indicated for everyone, only those at risk, and most guidelines recommend that varnish is applied 2 to 4 times a year for children with moderate to high risk to help reduce the incidence of caries. Okay, so getting medical providers to actually look in front of the tonsils was a challenge at first for the Bassett School-Based Health Program. To help with this, we used a formal paper risk assessment tool at every child's physical exam, annual physical exam, and that's helped. There are many different risk assessment tools out there that have been developed by various agencies, and we are currently using the American Academy of Pediatrics Bright Futures version. And what a risk assessment tool does is it assesses risk for caries from many different perspectives, including population demographics, socioeconomic factors, dietary habits, as well as clinical findings, what the teeth look like in our office in front of us. So let me switch over to a better picture of the Bright Futures risk assessment tool. And this is what it looks like. It's busy. There's a lot of questions to answer, but once you've done it 2 or 3 times, it goes very fast. When a patient is roomed, the LPN or assistant will ask about frequent snacking and determine their Medicaid eligibility, maybe if they've been to a dentist before, and then the provider assesses clinical findings. Okay. So what do we look for as providers? While most medical providers would identify the caries shown in the bottom 2 pictures, many don't realize that the top picture is incipient caries or white spot caries, and those will lead to a mouth that looks like the bottom 2 pictures. It's very easy to miss incipient caries, particularly if providers aren't lifting the top lip, and that's something that we aren't necessarily accustomed to doing. So just something simple like lifting the lip to look for those white spot caries can make a big difference. Once a patient is determined to be at risk for caries, a consent to apply fluoride varnish twice during the school year is sent home. But one of our challenges here has been that less than 50% of those consents actually make their way back to our office in the school-based health program because the parent isn't necessarily with us when we're doing their child's physical exam. So follow-up phone calls can help improve this, but finding time for those phone calls can be challenging. Okay, so once we have the consent back, fluoride varnish application in the school-based health setting is the easy part. Once staff have committed to using a risk assessment tool with every physical exam on every patient, parents have signed on, it's easy to paint that varnish right on. We do 2 applications annually on the medical side so that students do not get more than 4 applications between their medical and dental providers, whether that's the school-based health dental program or a private dentist. I should point out that there are some third-party payers that are requiring a training certification for medical providers before they'll reimburse. So Bassett has chosen to train all of its pediatric providers with the Smiles for Life online curriculum, which really only takes about 1 hour. Reimbursement for fluoride varnish by Medicaid can vary by state, so that's something to check on. In New York State, we reimburse for varnish by medical providers up to age 7. But really, it only takes about 15 seconds to apply on each child. But it really can drastically help remineralize that enamel and result in fewer caries down the line. Okay, Oral Health America is something I want to tell you about. They are a nonprofit organization focused on dental care. So even if your state Medicaid program does not reimburse for varnish, you may be able to get donated product to your nonprofit facility through their Smiles Across America program. We've had a lot of success with Oral Health America donating fluoride varnish, and it's allowed us to apply varnish on more children than we may have been able to. In addition to stratifying risk and applying varnish where indicated, students receive nutritional counseling both at their physical exams and other times. We concentrate on the 5210 model, as has been mentioned already today, and this, if you're not familiar, is 5 servings of fruits and vegetables, 2 hours of screen time, 1 hour of exercise, and no sugar-sweetened beverages. On the medical side, we often speak to students about sugar-sweetened drinks, particularly athletes who believe they need that Gatorade to make it all through their maybe 90-minute practice. You can see from the table here that Gatorade has a pH just a few steps above battery acid, and you combine that with the impressive sugar content and it'll do a number on athletes' teeth. Also, we'll counsel patients that sipping all day can be harmful, especially with sugar-sweetened beverages. Every sip counts as an exposure, so when they sip that battery acid sugary drink cocktail, that can result in even more damage. So we reinforce that water is the best way to maintain their hydration. Referral to dental care is something that we spend a lot of time on. Once we have a child at risk for dental caries or one who has caries and no dental home identified, we have an obligation to refer that child to definitive care, just like if we found a heart murmur and referred to cardiology. We will refer children both to the school-based health dental program, but also to outside dental offices. While we're lucky to have Dr. Carpenter serving our students, she doesn't serve students in all of our schools. And there are also times where she's in another school, maybe 50 miles away, and the child has an abscess, so they need more urgent care than what the parent might be willing to provide with Dr. Carpenter. So those students receive active case management either by an RDH who might be involved in their care, the hygienist, or by the medical provider. So the medical provider has, in our system, takes ownership of that problem and makes sure that the child is seen for definitive dental care. One thing that really helps with this, we've got a staff member with the Bassett School-Based Health Center who maintains an area dental referral guide. And this is set up by county and by insurance program. So this database can be shared with parents in paper form, or we can use it in-house to make direct referrals from our office. I can tell from personal experience that when I call a dental office locally to make a referral and speak to the dentist directly, I have higher chances that they'll be seen in an urgent manner. Our school-based health dental team that we refer to consists of 4 registered dental hygienists, a dental assistant, and Dr. Carpenter. And together with the medical staff at Bassett, we're able to provide risk-based comprehensive oral health care.
This is Jane again. None of this work happens magically or gets paid for magically. So we have been really honored to be recipients of a number of grants and fundings from a different organization. So we received a New York State Department of Health grant that supports our preventative dental services. We were recipients of the Children's Oral Health Access Project grant from HRSA. That was a 4-year grant, and that's just about wrapping up now. And most recently, we mentioned that we were recipients of a Dental Trade Alliance Foundation grant. With all of this, I would, urge you all, if you're interested in this work or really any work involved in school-based health or oral health, we're always trying to kind of come up with an innovative, new approach to things that are going to work in our communities. And what works in our communities and our school-based health centers may not work in yours, but maybe there's a few tidbits that can, and then you kind of tweak it to make it best fit. We learned long ago that we don't run after the money. We really come up with a project and then we try to find some funding for it. So we really talk about our funding as being a patchwork quilt, because along with all of this, we do bill children's insurance for the services we provide if they have insurance. We collect no out-of-pocket money at all from parents. There's no co-pays. There's no balance billing. So we are dependent on this other funding to support the program. I think that is it for this afternoon. We'll be anxious to answer any questions. We're going to show you our contact information. Again, I would urge you to go on YouTube and look at those videos. There's actually a series of, I think, 5 or 6 of them, and they deal with different aspects of oral health care. And they were funded by the HRSA project. So thank you very much.
Thank you so much to our panelists. At this time, we would like to take a couple of questions. It looks like we have a couple questions in the box, so in the interest of time, I will read the first few that are in the box for your responses, panelists. The first one is, how do you address the effects of extractions, bleeding from extractions, post-op discomfort while the students are in school? Does it disrupt their performance in school? And does it affect the students to see the post-op effects? I'm sorry, does it affect other students to see the post-op effects?
So I think that's a Dr. Carpenter question. I'll take that one. First of all, we do have parents come to the extraction appointment. So in addition to that first treatment planning appointment, parents are required to come to the extraction appointment. And kids will be taken home after the extraction. We give the parents a heads up that they will need to go home, take it easy for the day. I will say that a few times kids have had baby teeth extracted and then 20 minutes later begged their parents to come back to school. So in that case, we had to let the teachers know that that was okay for them to come back because it was just a minor extraction or a root tip or something like that. We always send the parents home with oral and written post-op instructions. So if they have any questions, they can refer to that written post-op instruction sheet, and they can always get a hold of me night or day. I give my cell phone number to the school-based health center so that if parents call and they have an urgent need, they can always get a hold of me. Has it ever been utilized? Very rarely. You know, it's very unusual that parents actually do need to call. So, and then as far as I think there was a part of the question about effects on the other kids. I wish I could be a fly on the wall when these kids go back to school and tell about their dental experiences. Unfortunately, I can't. But I think overall it's pretty good. I mean, we've had kids that have talked about their classmates coming in for care and like, oh, so-and-so came in and she had a tooth pulled and it was cool. So, and, you know, when all else fails, we give tons of prizes. So, you know, especially for the younger kids, we give out lots of stickers, lots of prizes, lots of tiaras. I wish I could give ponies on occasion. So we really try to make it a positive experience so that, you know, should a classmate see that, you know, little Johnny had a tooth out, he's not going to be afraid to come see us, you know, next week.
Thank you. We have time for one more question. Let me say that the questions that have come into the box, I will forward them to the team. And you can also reach out to them via the contact information that was up on your screen. It will also be available on our website with the archived version of this presentation. The second question, is the Caries risk assessment tool a national tool or one used just for Bassett Healthcare?
This is Carissa, and I'll answer that question. The risk assessment tool that we use was generated by the Bright Futures, which is part of American Academy of Pediatrics. So it's a national tool. We did call it down a little bit, though. It's quite extensive, and so we have eliminated some of those questions and are integrating it into our electronic health record so that the LPN or whoever's rooming the patient can ask a few questions. Then we look at the clinical findings and come up with a composite score to base fluoride varnish recommendations on. So it's a little of both, a little bit national, and but it's customized to Bassett's use.
Thank you so much. At this time, we would like to share some exciting news with you. The School-Based Health Alliance has been awarded a grant by DentaQuest Foundation to facilitate systems change for the inclusion of oral health services in the nation's 10 largest school districts. The objectives of this project are, one, to assess the capacity and readiness of school districts to engage in a collaborative. Number two, to bring together a panel of experts to advise and provide expert content to the Learning Collaborative. And number three, to establish a framework and curriculum based on national best practices. If you would like more information about this initiative, please contact our staff here at School-Based Health Alliance, Donna Behrens, and her contact information is there, and also Kate Schechter, who can be reached via the information there. You can always visit our website for these persons' contact information and the best way to get in contact with them. As you all are probably aware, School-Based Health Alliance is a membership organization, and we rely on our support of our members to continue to work as the national voice of school-based health care. If you're not currently a member of School-Based Health Alliance, we hope that you consider joining. We have two types of membership, one individual and one organizational, and this information can also be found on our website. Just a few closing reminders. This presentation has been recorded and will be archived on our website within the next 3 to 5 business days. If you are looking for additional support, technical assistance as it relates to oral health or school-based health care, please send us an email at programs@sbh4all.org, and we would be happy to help you. At this time, we ask that you take a moment to complete the 4 poll questions that will appear on your screen. Poll question number 1, did this presentation meet your needs? Five more seconds. Number 2, how well did the presentation meet the stated objectives? Five more seconds. Question number 3, how likely are you to apply the information from today's presentation in your organization? Five more seconds. And the final poll question for today, Would you recommend this webinar to others? Five more seconds. Again, we thank you so much for attending today's webinar. You can always reach out to us with more questions as they come up at programs@sbhforall.org. Have a great day.